Pure Urologist. Good evening, one and all. Today, our topic is supine PCNL complicated cases. In the last 10 years, lot of youngsters are doing supine PCNL, and the youngsters have become experts in supine PCNL. They are doing advanced cases also. Some are not doing prone at all in their career. One such consultant is now Dr. Sandeep Gupta. He is not very youngster. He acquired last 5 to 7 years knowledge in the endourology and the enucleation and laparoscopy. I will share his CV. In the recent so I am sharing his CV. Just a second. Yeah. So Dr. Sandeep Gupta is MS MCH Urology Gold Medalist. He is a fellow in 3D laparoscopic urology. He is working as professor and head of the Department of Urology, RG Medical College and Hospital, Kolkata. I really don't remember. I have to ask him when he finished his MCH. But of late, I have seen in West Zone, he is very active. He has shown live demonstrations in Nepal. He has shown live demonstration in West Bengal, Kolkata. Definitely is not very junior. He is senior consultant endourologist, laparoscopic robotic transplant neurosurgeon, ILS group of hospitals. Ex-member of State Transplant Inspection Committee, Human Organ Transplantation, Government of West Bengal. Present member, Authorization Committee of Human Organ Transplantation, Government of West Bengal. Author of more than 150 national and international index publications. I'm sorry, he is very senior, but by looks, he appears junior to me. And Sandeep, you have been really in good position.
Thank you, sir. Sir, I passed my MCH in 2014, sir.
2014.
Sir.
That means 10 years. I thought.
Sir, Sinam is my guide, sir. Professor Sinam, Rajendra Sinam, sir.
Rajendra Sinam is your guide.
Yes.
And you did your MBBS from which place?
Sir, I did my MBBS from Manipal, sir.
Manipal. Primarily, you belong to West Bengal?
Yes, sir. Yes, sir.
MS from?
MS from Ramaya Medical College, Bangalore, sir.
So all are very good academic as well as prestigious institutions. Manipal, main Manipal?
No, sir, in the Pokhara.
Okay. After that, you did in Ramaya and then MCH from?
RIMS Imphal, sir, under Rajendra Sinam, sir.
Oh, very good.
Imphal.
Very good.
Sir.
So after that, you settled in Bengal?
Yes, sir. Yes, sir. My great-grandfather is from Rajasthan, sir. We migrated from Rajasthan to Bengal. And I'm born and brought in
this RG Medical College, you are the HOD now?
Yes, sir. I was in SSKM for 12 years, sir. Then in 2022, I became prof. And I was in Bhadwan Medical College for 2 years. And for the last 8 months, I'm the head of Department of RG.
Transplant activity in West Bengal is very good?
Sir, in the government setup, we are doing mainly in SSKM, IPGMER hospital. And nowadays, recently started in NRS Medical College also. And
what about in private sector transplant?
Private sector, sir, many transplants are like I'm in the authorization committee. So every 2 weeks we have our meeting and there are 60 to 70 applicants per meeting. So unrelated transplants are, because in our state unrelated are allowed. So from other states, patients are coming in a lot of volume, even from Bangladesh and Bhutan. So that's why the volume of non-related transplants is very
unrelated means they have to justify how they are giving now, of course.
Yes, sir. Yes, sir.
You have to certify that justification.
Yes, sir.
You have to certify, but liberality is there to certify.
Yes, sir. Liberality. Actually, the police verification and all, they get it done. So if the police give the clearance that there is no monetary transaction, then we are no one to stop them.
Great. Sir. In our area, it is very difficult, more stringent, not only police. I'm happy that government also should take little more efforts to give liberty instead of thinking negatively always. Of course, monetary, all these things should be inspected, but lot of people will get benefited with the transplant programs. Now in Pan India, youngsters are doing transplant very well and results are also good and life we can add. Anyway, I'm happy that you are well versed and you are in government institute and you are academic and you are doing live surgeries. Very, very happy to have you today. So
Thank
feel
you, sir.
free to present your cases.
Thank you, sir.
We will be very happy. Over to you. Thank you, Dr. Sandeep Gupta.
Sir, thank you, sir. Sir, first of all, sir, good evening, sir. And I really thank you for giving me this opportunity, sir. In the last few years, sir, I am one of your huge fan and you are a mentor to me also. I've already told you this before. I really look up to you and the way, sir, you are managing the show and the way you are doing everywhere you are going and also managing your own institute very few people can do that. So there are a lot of things to learn from you, sir. I hope that youngsters who are younger than me, they just gain from your so much of expertise and they learn from you a lot, sir.
Good.
Sir, I would like to now start my presentation.
Yeah.
Sir, yes, sir. So I'll just, sir, initially just give a brief overview, sir, of supine PCNL. Like, sir, when I started supine PCNL in 2015, very few people used to do supine at that time. And in fact, when I started, people also discouraged me why you want to do it. Was 2015, sir, at that time.
In fact, I started in 2018. I'm sorry to say, 2018, 19, I started.
Sir.
So you started way early. Great. Highly appreciated.
Sir, my first case, sir, I did as a compulsion, more of a compulsion, because the anesthetist refused to give GA in prone position. So I had to do the case. So I thought, why not do supine? That's how my first case started, sir. So once initial few cases I did and it went smoothly. So I was like, I got more interest and that's how my interest and this thing confidence developed in supine. Next slide.
Yeah, you, Rajendra.
Please give me the control, Mr. Rajendra.
What are we doing? Huh?
Okay, so evolution of PCNL, like we have in 1970s, the classic prone PCNL, and then reverse lithotomy position. Then in 1990s, actually, the supine position started being done in many places. And the first series of PCNL while supine was also reported in the year 1990. Then modified supine PCNL started taking place. Then split leg prone position, then flank roll position. There were many positions which were developed in supine PCNL. Then the lateral decubitus, then GMSV position was initially introduced in 2007. So it actually renewed the interest for supine PCNL. So Galdeco modified Valdivia supine position was the main position which people started doing supine in. Then there were many other modifications. One of the famous modifications was the Bart's technique. It was very good and it was simultaneous antegrade and retrograde access was also possible. Hence, Bart's technique is also gaining popularity in many places. Then came the complete supine, which is the true supine. So in my last 10 years, I was doing the GMSV position, that is Galdeco modified supine Valdivia position. But just 2 days back, I did my first complete supine position. We have Dr. Vimal Dikshit, who is mainly doing all his supines in true supine. So actually, I saw Vimal operating in Kathmandu along with me. And I saw that, yes, it's a good position. So why not try? So just few days back, I did my first case in complete supine position. I'll show you the image also of the position. And I must say that it's also a good position. The main advantage is you don't have to make the patient lithotomy. And even the the cystoscope also went in very easily. And the ureteric catheterization was also done in the truly supine position. So I will suggest in terms of positions, if you want to do supine, then either go for GMSV position or go for true supine position. These are really good positions for doing supine PCNL. Next. So again, a chronological order of how the supine positions got evolved. So starting from the original supine by Valdivia in 1987, we have now the Bart's flank-free approach and the true supine position also. Yeah, next. Please help me. So prone, we'll just skip this slide. So prone is obviously believed to be the safest. Next. Then reverse lithotomy, we'll skip all this. These are all, I'll next please, next. I'll show the images, yes. This is the prone flex position. Next. Next, please. Yeah. So here we break the table in this position. Next. Then modified lateral position for simultaneous antegrade and retrograde axis. This is the Bart's technique. This is the Bart's technique. Then we have the Valdivia position. So in the original Valdivia position, please wait. Last slide, please. Yeah. In the original Valdivia position, we see that there is bolsters. There is use of bolsters in between the table and the body. But in the modified position, the bolsters are also removed. Next, please. Then they come the complete supine position. Then the modified Valdivia position. Next, please. Yes, next, please. Yes. So this is actually the Galdeco modified Valdivia supine position. So here what happened, the ipsilateral leg is totally straight and the contralateral leg is abducted as much as possible. So you get a space in between the two legs to do the ECIRS or even for ureteric catheterization, you have a lot of space. And the ipsilateral hand, the ipsilateral upper limb is slightly rotated towards the contralateral side. So this is the Galdeco modified supine Valdivia position. Next slide, please. Next, please. Yes. So this is how
it is taking.
This is cross leg position. Next. So yes. So we have the Bart's flank-free modified supine position in which the patient is supine with a 15-degree tilt of the ipsilateral flank made by using a saline bag under the rib cage and a gel pad under the pelvis. We'll show the pic. Next, please. Yes. So it offers a large surface area for access with easy manipulation of the nephroscope as the trunk is placed at 90 to the operating table. However, renal access is not always forthright. This is mainly important or useful if we do a USG guided puncture. Next. So coming to the most commonly used position, which is the GMSV position. Next, please. Yes. So by diagrams, I have just tried to show how the patient is positioned on table. Next. Yes. Next. Yes. So in my initial period, I used to place a small bolster in between the body and the table. But nowadays, I have totally removed the bolster for the last 5-7 years. Next, please. Yes. So now I do in this position. This is the Galdeco modified supine Valdivia position.
That means there are no bolsters here?
No, sir, no bolsters. And
I am still using bolsters in the chest as well as the under the hip. Do you think it is not necessary to have the enough space on the line? Not necessary.
Sir, with due regards to you, sir, for the last 7 years, I have removed, sir, and I'm doing without bolsters. So, I mean, I'm comfortable, sir.
Okay, okay.
Sir, this is the case I did 2 days back, true supine. So in true supine, sir, we have the patient fully flat on the table, no bolster.
But you may not get access to ECRS. In case if you don't want ECRS, you can make it like this.
Yes, sir. True.
Okay.
And the arms. So this is the true supine position, sir.
Arms are also same side.
Say, sir, just like a Christ position.
Like a patient sleeping.
Yes, sir. Christ, Jesus Christ, crucified position, sir.
Oh.
And sir, the CM, sir, is always while puncture, the CM is always tilted 20 degree towards me. Always.
towards the head and towards the surgeon.
Toward the surgeon, always. My punctures
What
are
is the
always-
reason? What is the reason to have better spine-free space?
Yes, sir. That is one reason. And one thing is, sir, if I do in 0 degree, I've noticed, sir, that the stone and the vertebra, sir, they many times they overlap, sir.
Yeah, that's what. This overlap it decreases, huh?
Yes, sir. Yes, sir. 20 degree, it totally we see at
Very,
suspect
very
angle.
important point. Very, very important point you are mentioning. Thank you. We'll see. I will
Sir.
also see next time. Okay.
Sir, so obviously the OT table should be radiolucent. It can be sufficiently translated, leaving the abdomen free of radiopaque obstacles, and it should easily host the CM. Very important, sir. Many times I've seen when I do in some unknown place, a new place, I positioned the patient, then they are telling that, sir, CM is not entering the table. So before positioning the patient, always make sure the CM is comfortably going into the table and the way I want it. The way I always make it turn 20 degree towards me. Again, I make it 0 degree away from me. So all that I do, only then I position the patient in the GMSP.
Actually, we have to see the rod of the CM table also should be completely not coming in the field of the CM.
Very important, sir. Very
Table actually head and upraising table is good actually for urologist.
Sir.
The central station should be at the head end, so that
Yes,
rest
sir.
of the place will be CM compatible, isn't it?
Yes, sir. Sir, actually, sir, people like me, we are also having to do sometimes in small places like freelance. So there, maybe once in a blue moon, I'm going, and there suddenly, after everything, I'm seeing that the CM only is not entering the table. So we face such problems, sir.
Yeah, that is a very tricky situation.
Sir.
And very difficult to puncture in such cases, especially live workshops. I have seen struggling myself.
Sir.
You have to check the CM first for the position. Okay. So,
sir, another important point I want to make is the bowel preparation, sir. Sir, I'm sure, sir, you are also doing, I think, bowel preparation one day before, sir.
Bowel preparation in supine PCNL?
Yes, sir.
What preparation you will give?
Sir, either liquid diet one day before and sir, if required, a peg leg or a pea enema, something, sir. To
Why?
Sir, because to decrease the chance of bowel injury, sir.
Oh, it's anyway. We will discuss about it. We will move further.
Okay, sir. So
okay,
next
no
slide,
problem.
please, sir. So I'm just showing that how the contralateral arm is raised to the opposite side and how the ipsilateral arm is placed over the patient's chest.
Okay.
Next, please. And sir, one other thing is marking, sir. So like some people are doing the markings, the 3 important landmarks markings, like before the patient is shifted to the theater. But for me, all the bony landmarks I mark after the patient is positioned, sir.
Okay.
So just the OT setup. And now we are coming to the 3 important landmarks for supine PCNL. The anatomical landmarks. The most important is the posterior axillary line. Whatever it may be, never we should puncture anterior to the posterior axillary line. So the most important anatomical landmark marking in supine PCNL is the posterior axillary line. If
actually you will be much posterior to that most of the time, na?
Yes, sir. Sir, as beginners, practically, sir, as posterior as possible. As beginners, definitely, sir, because 1 or 2 cases of bowel injury and your morale will be totally down. And then we won't want to proceed with supine any further. So just a table of some advantages and disadvantages of supine. I'm not telling supine is the best and every case supine. No, supine has got its own limitations. We should know when not to do supine. We should not just for ego's sake do every case supine. No. So advantage as mentioned, cardiovascular.
I am reading disadvantages.
Yes, sir.
Correct. Very nicely written. Disadvantages you have nicely written. Excellent 7 points. Okay.
So next slide. Again, just
We will move
comparing the
forward.
various, pardon, sir.
We will move forward to the cases because
Sure,
you
sir.
have
Sure,
to,
sir. Sir, just one important, this slide I want to show, sir. One important slide.
Yeah.
Sir, the last slide. Yes, sir.
Sorry.
This is one slide which I made 5-6 years back. It was also published in our USI newsletter. Like how to know whether our puncture is in the system or anterior to the system or posterior to the system. Very important, sir. So as I said, sir, I puncture in 20 degree. Then I move the Siam away from me to 0 degree. So if in both the positions, my tip of the IP needle and the stone coincide or the calyx coincide, means 99% most likely I'm in the system. But if on changing the position from 20 degree to 0 degree away from me, if the tip of the IP needle moves lateral in relation to the stone, that means I am superficial to the stone. That means in supine position, I am in a more anterior relation.
Yeah.
And similarly, if my tip of the needle moves medial in relation to the stone after moving the Siam from 20 degree to 0 degree, that means I am in a deeper position, means I am in a more posterior position in supine. That is one message I want to give to the youngsters because they are always confused. So lateral superficial LS and medial deep MD. That is how they can remember.
Yeah.
Sir, now I'll just present my video of complex situations.
Yeah. We are opening that. Yes, give me a second time.
Sir.
See, this 20-degree turning in the beginning and puncturing, I am listening first time. I will try next case and let you know.
Sir.
Because overlap of the stone on the spine is a common problem. Sometimes lower calyx, I face a lot of problem. So let me try this 20 degree towards the side, which we do in prone PCNL 30 degree, 0 degree. But what we do head and tilt, down and tilt.
Yes.
But this 20 degree towards the surgeon will be common like prone to supine. So people will not get confused. True. So are you starting the video?
Sir.
You are taking over yourself?
Yes, sir. I'll take it, sir. The video I'll start.
Yeah, video take over, please. Yeah.
Sir, am I visible?
Yes. Your video is visible. Your audio is clear.
Thank you, sir. So I'll present 6-7 interesting cases of supine PCNL.
All are in this video or separate videos?
Single video, sir.
Single video, so don't fast forward.
Okay, sir.
Don't fast forward.
Okay, sir. So this slide I'm just skipping because already discussed in my presentation.
Video we are not able to see. Okay. Video?
So video is playing now, sir?
Video is playing.
Okay.
It's okay.
Just a brief overview. So first case, sir, it was a case of right-sided duplex moiety stone, sir, a 20-year female with stone in the right lower moiety.
Yeah.
So I thought of presenting this case because it was a duplex moiety.
Can you put off the sound music so that we can clear?
Okay, music over. Mute, sir.
Music out.
Now, sir?
No. Yeah, now it is not there. Very good.
Okay, sir. So, sir, I've tried to do a PIP technique.
Yeah.
So it's a 2x speed, sir, so that the video duration is short. And sir, I always do a single step puncture. I have always mentioned this. Single step dilatation. All my dilatation.
But won't it be very difficult in supine kidney moves and you may overshoot? I feel really difficult in single step. Sorry, but you are doing all the cases single step?
Sir, I always use my 24 French single step dilator, sir. Always. Screw dilator. That is the one I use, sir, always.
You have also done prone PCNL a lot?
Yes, sir. Prone, many, sir. Many.
Very good. So this is a bifid system. You perforated the punctured the bifid.
Yes, sir. Now a supine in horseshoe kidney. So this was a very interesting case, sir. The patient had been operated many years back for right side, but he came to us with a retained stent. it was a retained DJ stent with a bladder calculus and multiple stones in the right kidney. So first sitting, we removed the bladder stone with open cystolithotomy and we removed the lower end of the stent. In the second sitting, we performed supine PCNL to remove the upper end of the stent and the remaining stone fragments in the kidney.
You did open, why?
Sir, bladder stones, open cystolithotomy, sir, bladder.
Okay.
But this is now supine PCNL for the kidney stone and the upper end of the stent.
Okay.
And sir, in supine position in horseshoe kidney, it is always advisable to go through the middle or lower calyx, sir.
Yeah.
This, sir, we discussed this time in Percon also, sir, under
Yes.
you. Sir.
Yes.
So we have removed all of the stones along with the upper end of the fragmented stent.
Just you pause here. I want to ask one question.
Sir.
The malrotated kidney in horseshoe kidney,
Yes, sir.
it is anteriorly malrotated. Calyx approach through the prone is easy, people say, and I also feel. In supine, in this case, RGP, I am not able to see. If it is RGP, do you think any difference in normal kidney and horseshoe kidney in supine PCNL, honestly?
Sir, in RGP, sir?
Yeah, RGP and puncturing in horseshoe kidney. Particularly, horseshoe kidney is anteriorly rotated.
Yes, sir.
So
Yes.
there is no lateral part of the calyx so well in
Yes.
horseshoe kidney. So won't it be difficult to do supine PCNL horseshoe kidney? I feel.
Yes, yes, sir. It is difficult, sir. And I did my first supine horseshoe in 2017, sir. I got one case. I was in IPGMR at that time. And I presented it in East Zone also. So I still remember Dr. Shivaji Basu, sir, our so senior consultant.
Yes.
Sir, literally means he was literally angry on me that why you attempted supine for a horseshoe kidney. But I said, sir, I tried and it went successful. So till now, around 7 horseshoe I've done, sir, in supine.
So
and
you like to do supine only in horseshoe kidney first chance?
Yes, sir. And I've also had 2 publications also I've made, sir, of horseshoe in supine. Already papers also published. And so far, none of the patients have any problems, sir.
Very good. Okay, right. Go ahead.
So this is the post-op picture, sir, complete clearance. Then, sir, it was an interesting case of a cross-fused renal ectopia, right side, with a stone. So I did a lab-guided supine PCNL in this case, sir. He was a 16-year-old young male. He had a history of right pyelolithotomy also 10 years back. So in this case, the patient was truly supine, just like in lab, sir, we do. So lab-guided puncture I did.
You did puncture to the calyx or pelvis? Pelvis,
Sir, if you see, sir, here, there are 2 IP needles. So in my first puncture, I thought I've gone to the pelvis. So I did not dilate further. This is the second puncture and I went through the calyx, sir.
Very nice. This is I also done, but only one time I have done.
Sir, this is my only case, sir, in ectopic.
I think lifetime, each surgeon will get one time chance to do this, or
No,
maximum 2 times.
No, sir, you will get multiple because so many people will send you cases, sir.
No. Rare.
Sir, this is one supine in diverticular stone. So this was also interesting. Because,
in this case, you have moved very fast.
sir.
Stop it. When you puncture the PCS, what is the guide? Ultrasound, X-ray, CM? How do you puncture, or only direct laparoscopy puncture of the bulge?
In this cross-fused ectopia, sir?
Yeah. Cross-fused ectopia is not an easy case because vascular vessels may be there. You should be careful. Did you mobilize the peritoneum did you mobilize the peritoneum or directly you have gone?
No, sir. First, I mobilized the bowel and everything, sir.
Yeah.
And then under fluoro guidance, I punctured, sir.
So how do you do fluoro guided in ectopic kidney in pelvis? Fluoro milega? Fluoro aega?
Sir, we had taken, sir. We placed a UCAT, sir.
Okay. Normally sacrum will be there. It's only possible when the tilt is given, too much tilt is given and taken the pelvis.
Yeah, table we tilted, sir. The patient table we tilted a bit, sir.
Yeah.
So
So
that we could
what I
see.
have done is laparoscopic guided
Okay.
mobilization, and through the pelvis I have punctured. Through the pelvis only I have dilated. After that I have sutured the pelvis.
Okay, sir.
Because in cup kidney ectopic, calyx proper identification by by laparoscopical is difficult. Lot of people use ultrasound, but bowel will come. You are mentioning that CM is used. CM also can be used, but it is difficult. I next time when you do any pelvic kidney, try to record how the CM is used. It is difficult. It is tricky. It's like bladder stent. When you want to show, you show tilted CM like this. Sometimes senior X-ray technicians, they will tilt it 70 degrees and show whether the stent is in the bladder or not. Like that, we have to tilt the CM in such a way that the sacrum will not come in position. Do you agree?
Yes, sir. True, sir. True, sir. Next time I'll
Yeah.
try to record, sir.
Yeah. Okay. What is this case? Diverticular
Sir,
stone.
this is diverticular stone. So supine in
Before you show diverticular stone, if contrast is filled or not filled, does it make difference to you or no?
Sir, in this case, contrast did not go into the system at all. So it was more of a stone guided puncture, sir.
Okay. So after you stone guided puncture you did.
Yes, sir. Because we are seeing the calyces are filling up, but this diverticular bunch, sir, is not filling with the contrast, sir. The image quality is II image quality is a bit bad. So here, sir, we can see that dark black is the stone bunch. This is the stone bulk, sir. This.
Then guide wire has gone into PCS or not?
No, sir. No, sir. It was just means coiled in the diverticulum itself, sir.
If it coils, you are lucky. If it doesn't coil, it becomes very difficult, isn't it?
Yes, sir. Yes, sir.
So good. Diverticular stones are tricky. Sometimes when you go inside, diverticulum is not seen. After that, it is if the stone is big, it is better. What do you say?
Yes, sir. And sir, they also tend to go. So it were around, sir, 23 stones.
Okay.
And sir, most of my PCNLs are tubeless, sir. I don't insert a nephrostomy. This was, sir, this I want to show that even in staghorn we can do with a single puncture supine PCNL.
Yeah.
So that was the burden of the stone.
And in supine PCNL water flow, you require good water flow.
Sir,
What
very
will
much.
improve the water flow? One question.
Sir, I always tell use a pump, sir. Into the 3-liter bottle we insert a pump and we pump from there, so the flow increases.
Is it?
Yes, sir. I always use this pump, sir. Our BP cuff, sir, BP pump we have, our BP instrument.
Yeah. What is the standard size of ampla sheath and nephroscope you use?
Sir, 24 this thing, sir, sheath.
Which nephroscope is your favorite?
Dresden, sir.
Dresden, very good, sir. Okay.
So this it is nothing very unusual. This next case, it is a big stone in the pelvis, 3 centimeter. So that's why I thought I'll just show it. It's a big stone.
Okay.
Burden is very high.
Meaty kidney also.
Sir.
Yeah.
Last video, sir, I'll show it's of a horseshoe kidney. One more horseshoe I did just 2 weeks back. So I've included that also in the video. So I'm lucky because in government setup, sir, we are getting many unusual cases.
Yeah. And your juniors are also doing supine only?
Yes, sir. Some are doing, and even I always make sure my residents before they pass, they also do supine.
Supine.
Yes.
In my unit, all the 10 consultants are doing supine only. In fact, I do prone alternative, but they are reluctant to go for prone. You should learn both, I feel.
Definitely, sir. As you always say in every conference that
if you are master in both, you will be unbiased.
True, sir. So this is complete
But
clearance.
in staghorn, do you think that water will be more required for flow in supine PCNL? A little more.
Very much, sir. Very much, sir. Sir,
Very much.
we knew because the system is always collapsed in supine.
Collapsed.
Yes,
I
sir.
feel staghorn prone is easy because we feel stones comes out easily, but in staghorn, water flow will be good in prone, and you can pick it up big pieces and take it out.
Yes, sir.
It's a personal feeling.
Sir.
Staghorn, I feel prone is I personally feel, but
Sir,
can be both the ways. No
sir,
problem.
one advantage of supine, sir, with gravity, the stones come out, sir. That
Ah,
is
yeah,
one of the,
I am saying the same,
sir,
but with good amount of flow. Flow
yes,
is required.
like the whirlpool effect.
Yeah, yeah.
Sir, the last video is also of supine in horseshoe. One more horseshoe I did. So I just included it in the last moment. It was like a partial stack. It was occupying many calyces.
Yeah. This is also very thick kidney. Yeah. Nowadays, I am giving little importance to 12th rib than posterior axillary line. I am
Okay.
slightly comfortable. Each time, each surgeon, each case, you will try to derive some conclusions. So keep exchanging the knowledge. That's what I feel. So that, see, now 20-degree puncture you have told today. If I try and feel good, we have to exchange that knowledge. That is what exactly I mean to say.
Sir.
You are way below posterior axillary line. Very good. In all the cases, you are at the 12th rib team.
Sir, this one thing I want to show how the difficulty in supine, because sir, I wanted to go to the upper calyx, but because of the iliac crest, I was having great difficulty. So I told my assistant to release the foot, the right leg, and he was holding it with his hand.
That is a very important point you told. If you wanted to do only supine PCNL, there is no ECRS, nothing. Better to keep the patient leg straight. For especially lower calyx, it will hamper iliac crest will hamper. Whereas in prorita, the thigh, sorry, the gluteus muscle will hamper.
Sir.
One question: have you ever converted from prone to supine? Sorry, supine to prone.
Converted, sir? Not till now, sir.
I have also not converted. No, it won't require. If you learn proper supine, it's not that difficult that you have to convert to prone, and prone is easy. No.
Sir.
Next.
Sir, I'm done with my video, sir.
Yeah, one more question asked by the audience.
Yes,
what
sir.
are signs intraoperatively that suggest infection and need to terminate operation immediately? Pus, or you can close the screen.
Okay,
we
sir.
can interact. I will close.
Stop share, sir.
Yeah, tell me.
Sir, when to stop the surgery, sir? Yeah,
somebody asked that in which condition, even the infection is there, you will stop. I think frank pus you should stop.
Yes, sir, frank pus, sir. Definitely. Frank pus, we should definitely not proceed.
We should not proceed.
Sometimes what happens, we see a bit of cloudy urine. We give a wash from below through the UCAT, and clear urine comes. If the patient is under antibiotic good coverage.
In those cases, I must say supine is very good, because every drop of infected urine will come out. Chances of sepsis, intrarenal pressure will be low. Yes. But mind you, this all depends on outflow from the ampla sheath. And whenever we are in a teaching session or any message-oriented session, if you are in doubt, put nephrostomy, come out after 2 days, 3 days. My God, you will be saving the patient. Don't try to push and don't try to meddle too much in an infected system. Kidney will bleed. Infection can be disastrous. Antibiotics may not work. Sepsis can be detrimental during intraoperative period. So don't experiment in infected system. Either RIRS, ECRS, or supine PCNL. No. We'll take some questions. If you keep the patient completely supine, a common question everybody asks is upper calyceal puncture. Upper calyceal puncture, in almost all cases, a slightly medial puncture will be there. So if you keep straight supine, will you be able to see that calyx and puncture without tilting?
Sir, since
Upper calyxial.
my C-arms are always tilted 20 degrees, sir, towards me.
I mean, entry point is always accessible to you in flat, straight supine position.
Sir, true supine, I have just done one case, sir, which I told 2 days back.
So you are
So it
still,
was a pelvic stone, which was I went through the middle calyx. It was clean cut. I need to try, sir. I'll
yeah.
update you, sir.
Even I also tilt a little bit. See, complete non-tilting advantage is the hip will not come in your view. But lithotomy need not be necessary. Sometimes lithotomy is also tricky. If the hip is not flexible, sometimes it awkward angle if you put, patient may get pain in the postoperative period. Now, third question: in the lower calyx, if the stone is small, will you attempt lower calyxial puncture or middle calyxial puncture?
Stone is in lower calyx, sir.
Yeah. It is difficult to puncture a non-dilated lower calyx in supine PCNL is my question.
But if stone is in lower calyx, I'll go through lower calyx, sir.
Lower calyx, there is no problem for you in puncturing?
No. In
Supine
fact,
PCNL, you don't feel difficult in lower calyxial puncture?
no, sir. In fact, initial period,
Ah,
I always used to select stones in the pelvis and lower calyx.
ah,
And I used to attempt only those supine PCNLs.
okay. So what I am saying is that if the calyx is directed downwards towards the leg, that means paraspinal vertical lying calyx. It is laterality. If it is not there in supine PCNL, it is slightly difficult. If the lateral part of the calyx non-dilated system is there, I struggle in lower calyx. In that case, I go through the middle calyx and I can reach the lower, or else RIRS. Anyway, it is good that you are able
Like, sir,
to
in
do
Kathmandu, the case which Sanjay sir gave me, it was a lower calyxial stone, sir.
lower calyxial
I
stone.
went
Well,
to lower calyx.
yeah. The juniors are asking. Stefan Ansal is asking which position for your junior you will recommend. Modified Goldivia or modified.
Yes, sir. Yes, sir. Yes, sir. Because, sir,
So I think you tilt a little bit. You put a bolster. You have a little more access posterior to the rib. Then you will be a little more comfortable.
yes, sir.
If you are flat and try unnecessarily doing mistake, it is not good.
Initial few cases, sir, always go for the best, easiest technique to gain confidence. Then we can
If
always
you
experiment.
ureteric catheter flushing in supine PCNL, do you need one good person to constantly flush from ureteric catheter or pump is enough?
Sir, normally my assistant flushes with a 50 ml syringe, sir,
From ureteric catheter.
from ureteric catheter.
Even my assistant also flushes with ureteric catheter. That is too much necessary in supine PCNL, I feel. Whereas in prone, okay, if you don't have ureteric catheter also, water will stay like a well and you can pick up the stones in the well. Whereas in supine PCNL, well and collecting of fluid will not be there. So that is any bleeding in supine PCNL appears little more darker.
Yes,
Okay.
because less water.
Live conference, if you don't have good vision, people say it is bleeding more. But if you use water flushing, it will settle. Have you ever attempted multiple puncture, multiple dilatations in supine PCNL?
Not more than 2, sir.
Not more than 2. I have done in trifid system, bifid system, where I cannot go from one to other and stone burden is more. Do you do ECRS?
Yes, sir. We have attempted few cases, sir, simultaneous.
I do lot of ECRS. Even today, a pediatric case, large volume, bilateral 4 years baby. When I was doing, one stone has gone into ureter. So I have to put ureteroscope into the mid ureter and push it up so that I could retrieve back. That's a real advantage if at all any stone migrates. And degestant also you have shown. If any degestant large stone is there in the mid ureter, you can approach from below and above in ECRS. ECRS definitely has some role. We cannot deny that.
Yes.
Have you ever tried mini perk 15 by 12 in supine PCNL? No.
Sir, Kathmandu was mini, sir. So
Mini, okay.
with the 12 only.
12, yeah. Because did you use laser in that case?
Yes, sir. I use lasers.
Laser in that case. Okay. So if the calyces are falling onto the spine and you have difficulty, any other than 20-degree clue? In 20-degree, always it gets separated from
Yes,
spine.
sir. Yes, sir. 20-degree, I have never faced this overlapping problem, sir.
That's a very good point. That's a really, really good point. I must say it's a good point. During dilatation, the kidney moves a lot. Sometimes in single step dilatation, it may perforate the pelvis. I have done one perforation in child. You have to use a lot of force in children. Do you use hand to aid in the dilatation? Not necessary.
So actually, sir, the guide rod, the tip, sir, that is blunt. So the guide rod, normally, sir, it prevents the overshooting. And what I do, sir, I always go only 1 centimeter at a time with the corkscrew dilator. So
Okay.
very, very rarely a chance is there to overshoot. Very rarely.
Yeah.
It's a corkscrew dilator, sir.
Okay. And which needle and which guide wire you use in supine PCNL?
Sir, always a Terumo straight tip guide wire.
Sermo and do
And
you use
2
Alken rod always?
Sir, I use one after my puncture, sir. Once the guide wire is secured, the first thing I use is my two-step alkane metal. One dilator is there, two-step alkane metal dilator.
Okay.
I always use it. Even Kathmandu, I carried it. Luckily, I carried it because Sanjay sir didn't have it. And then over that, I go for a guide rod. And then over the guide rod, this single-step dilator. That's all.
Good. Again, same question. To decrease the motility of the kidney, what will you do? I use my left hand under C-arm. It radiates your arm also, but short bursts. In children, it is very, very. You can feel the kidney. You can feel and stop the kidney, and it's really, really useful in children. Adults, it's okay. As you say, store dilatation with screw can do the job.
Another thing, sir, my anesthetist, I always tell them to hold the kidney during my puncture.
Yeah. So I had difficulty to remove it. How to anticipate? Why only 20 degrees and not 30 or 10 degrees? Sandeep has asked. That's a good question.
Sir, 20, 30, I mean, like SK Pulse is 30-degree, the gradual ascent. So, gradual descent, sorry. So,
actually, it's a very good question.
Okay, sir.
It's a very, very good question. I like to answer that, if you permit.
Sir, please, sir.
See, whenever you have a stone in the system and if you puncture, if your needle is in the PCS, it should be there in PCS 0, 10, 5, 20, 30, 40, 50, 60, 100, 180. The needle in PCS, whatever angle you see all around, it should be in PCS. So it does not make any difference. But the problem with 30-degree is your orientation with the PCS gets little abnormal. We are all oriented to 0-degree. Medial lateral is well assessed in 0. In supine PCNL, if you turn 20-degree, you need to orient a little bit medial lateral and then you have to go back to 0. It cannot be done easily in a monoplanar technique. Lot of prone PCNL surgeons, even supine myself, in 0-degree, I can do monoplanar by movement, the calyx moves and then you puncture, then you get water, fine. No other degree, no other movement. But if you keep in turned position already, for example, in bullseye technique or in 20-degree technique, you need two planes. In that case, a little lesser than 30-degree, slightly better, I feel. What he mentioned, it is a good point to be noted today. And I will try 20-degree position in the initial puncture just to keep the pelvic calcium system lateral to the spine. It is a very good point. So with this, it is a nice session and you might have made a little more bigger videos I might have enjoyed, but because of time constraint, you made it precise. Next time, teaching video you make in Arshu kidney whenever you are doing, and only Arshu kidney, all aspects of anatomical, the puncture aspects you let us know because you did 6, 7. I did, I think, 3, 4. If the lateral part of the calyx, my feeling in supine PCNL is if the calyx is seen facing laterally, I can puncture. If the calyx is seen laterally, you can do supine PCNL any position, anywhere in the line. So each person has modified supine because there are no fixed landmarks, there is no fixed method. That's why people comment that it is not good to have so many positions. Nothing like that. For anesthetist, supine PCNL is very, very, very comfortable. As Sandeep Gupta told, he started with anesthetist request. Today morning, I asked anesthetist, "Are you comfortable in the child in prone?" He said, "No, no, sir. Please do in supine PCNL." So there is a meaning in it. It's not to promote supine PCNL. Luxury for the anesthetist to have airway control. See, people do under spinal in prone also. That's fine. But as the time goes on, which position is good for anesthetist to reintubate, extubate, everything matters. If you prolong the surgery, controlling of the jugular venous system, everything is easy in supine. In addition to that, I say that if ECRS is indicated, bifid, trifid system, retained DJ stent, very, very obese patient, very sick patient where prone cannot be given, supine has. Even for PCN, in a severe pyonephrosis and sick patient, hypotension and noradrenaline, supine is luxury, like just in puncture, ultrasound guided or CM guided. So it's really luxury. So thank you, Sandeep Gupta. I must really appreciate. You are already a HOD. I didn't know. I was thinking you are the HOD and department head. You will have a lot of bright future and you will train so many students. That is a very fortunate thing. And try to train and teach in all aspects, including the non-supine PCL also.
My
Wish you all
final
the
year, sir, one is from Andhra only, Shiv Manohar. He's about to pass in December.
very good, very
So
good.
I told him, if possible, join with you.
Yeah, very good. And you teach like that. I always respect those who work in government institutions. I used to say from my MBBS days that they are existing gods because tomorrow our children also have to study under you and learn. You people work for the salary and it is a divinely thing. So continue teaching. It will help the needy.
Thank you so much, sir.
Thank you very much.
It was an honor, sir. Thank you, sir.
Thank you.